Well, good afternoon, everyone. Thank you for coming. It's really an honor to be here today and talk about Dr. Leon Schiff and introduce our annual speaker. So this lectureship was installed since Dr. Schiff's death in 1994 in honor of this amazing hepatologist. And to tell you just a little bit about him, when he came to the United States from Latvia, he built his career at the University of Cincinnati, where he went on to become full professor. He built there the first gastric laboratory, which became one of the first divisions of gastroenterology in the country. He was among the first to use diagnostic endoscopy. There he taught and mentored dozens of trainees who also went on to become prominent gastroenterologists. And he made a lot of strides. He became nationally and internationally renowned. He was a founding member of the AASLD, which is our liver society, and was the very first president of the AASLD. For those who don't know, for our luminal folks, he was also a founding member of the ASGE, the Gastrointestinal Endoscopy Society in the United States. Among his work, so he published hundreds of papers, and he edited one of the most prominent textbooks in hepatology, which is now in its 12th edition. So we continue to edit that. And once he retired from University of Cincinnati, he came to the University of Miami, and here he founded the first division of hepatology. And together with Gene Schiff, he then founded the Center for Liver Disease, which was later renamed as the Schiff Center for Liver Diseases, which you're all familiar with. So as in honor of Dr. Leon Schiff, we have established this annual named lectureship to bring another renowned hepatologist who can not only teach, but hopefully inspire all of you as you're starting and in the various moments of your journey in your career. So it's my pleasure now, Dr. Sanjana Rao will introduce Dr. Fasiha Kanwal, who is our invited speaker. Thank you.
Welcome. Dr. Fasiha Kanwal is a professor of medicine and the section chief of gastroenterology and hepatology at Baylor College of Medicine. Sorry about that. She served as the editor-in-chief for journals such as Clinical Gastroenterology and Hepatology and the American Gastroenterological Association Clinical Practice Journal. She's a nationally recognized authority in patient-centered research and in the epidemiology of clinical cirrhosis and hepatocellular cancer. Currently, she is leading as a translational research center for the National Cancer Institute Consortium in early detection of liver cancer. She serves as the co-PI for the Texas HCC Consortium and is leading an NCI-funded trial in HCC screening. She's also the director for the GIT 32 Fellowship Program at Baylor College of Medicine. Please join me in welcoming Dr. Kanwal as she discusses a management approach to patients with metabolic dysfunction-associated steatotic liver disease.
Thank you so very much. And I'm really honored to be here as part of the Schiff's lecture, and what a great legacy. So again, really grateful for this invitation and really had an opportunity to enjoy this beautiful city of Miami. I wish I had a longer time. And thank you all for joining. I'm really looking forward to spending the next hour with you here. So I had to think a little bit about what topic to present. So I chose this topic. So before I get started, two questions. First, can you hear me okay in the back? Perfect, awesome. And the second question is just a show of hand. How many of you have either seen, known, or taken care of a patient with what we used to call non-alcoholic fatty liver disease, so quite a few hands that I see. More are showing up. Yes, it's a very common condition. So I'm not surprised that you've seen or encountered a patient with fatty liver disease. And how many here know that we don't call it NAFLD anymore, that the name has changed? So excellent. So a lot of people actually are also aware that what we used to call NAFLD or NASH are now called MASLD or MASH. We're very creative about names, our society. But I'll talk a little bit about that. So yes, it's what we used to call NAFLD is called metabolic dysfunction associated steatotic liver disease, as we heard, or MASLD. And what we used to call NASH is called MASH, metabolic dysfunction associated steatohepatitis. So really, it has been a major change in the field with the change in the nomenclature. I'll go over this nomenclature change just very briefly before we get into the actual presentation. So this change was endorsed by multiple liver societies. It happened about a year ago. And it starts with this overarching term or umbrella term called steatotic liver disease. And as you can see on your left, what used to be called NAFLD is now called MASLD. And the more progressive steatohepatitis is now called MASH. One key aspect of this nomenclature change is that it acknowledges and accommodates patients who have both metabolic dysfunction and who are also drinking alcohol. So that's the group that was sort of ignored despite being a common group in the previous scheme, but now these patients are part of this scheme. Those are the patients who have metabolic risk factors and also drink moderate amount of alcohol. There's a new term for that. It's called MASLD. So that's something that I think you will start encountering and diagnosing these patients in your clinical practice. And of course, the alcohol-related liver disease, also steatotic liver disease, falls under the same umbrella. This nomenclature also encompasses patients with more rare steatotic liver diseases, just like drug-induced liver injury or monogenic diseases, and even cryptogenic. So this is an overarching scheme. It includes all patients who could have steatotic liver disease. And this is the very first time there's some sort of a conceptual framework that puts all of these groups together. So that's, I think, one important aspect of this. The second part is that it's not just a change in the name, there's also change in the definition of this condition, or MASLD. Now, as you know, previously, this was a diagnosis of exclusion. You had to exclude everything before you could classify a patient with NAFLD. This has changed. Now, with this new recommendation, it is an affirmative, a positive diagnosis. And this is very helpful decision support tool that you can use. For example, as part of the tool, if the patient has steatotic or hepatic steatosis, you can determine it with an ultrasound or a liver biopsy. Then you look for one of these 5 metabolic risk factors. So there is overweight or obesity, diabetes, prediabetes, hypertension, high plasma triglycerides, or low HDL. Any of these risk factors, you can diagnose the patient with MASLD. So it's a positive affirmative diagnosis. And as I just mentioned before, it allows for overlap. So you could look for patients who have MASLD and, let's say, hepatitis C, or MASLD and alcohol overlap. It allows for that flexibility that we encounter in our clinical practices, and before it was ignored. So that, I think, is an important change in the field that I want you to spend a few minutes talking about. But that's not the only thing that has changed in the last year or year and a half. That's why it's really important to talk about this condition. There have been advances and updates on the guidance on screening and risk stratification for patients, also on diagnosis and newer treatments. So in the next 45 minutes, I'm going to go over these updates with you. And my goal for this time with you is for you to walk away with at least one new piece of information that you can then put into your clinical practice. Does it sound okay? All right. All right. So with that, we'll start with a case for Mr. A. So Mr. A is a 57-year-old man. He has a history of type 2 diabetes. His BMI is 35. Hemoglobin A1C is 7.9. He tried to lose weight with lifestyle changes, was able to lose about 2 kilograms, but then he regained that 1 kilogram back. He's only taking metformin as a medication. His liver enzymes are listed here, mild elevation in his AST and in his ALT. Very familiar case, seen someone like that in your clinical encounters and clinical practice, I'm assuming in the last 1 year. So my question to you is that, does he need to be assessed or screened for MASLD and MASH? Show of hands, nod of your head. All right, sounds good. So yes, and I'll come back to that in a minute. And this is something that I think also is important for us to note. guidelines now support earlier MASLD screening and risk stratification. It wasn't the case up until just a few years ago. So back in 2020, there actually were no consistent recommendations or guidance for any sort of screening or risk stratification for people at risk from MASLD. It changed in 2021, which was not too long ago, with the American Gastroenterological Association, or AGA, convened a group of multiple people from different disciplines across the globe and published the first clinical care pathway or guidance that endorsed or recommended screening and risk stratification. So with that, very soon thereafter, multiple other societies endorsed and recommended the same approach to screening and risk stratification, including the Endocrine Society, American Association for the Study of Liver Diseases, the Diabetes Association, American Diabetes Association, and more recently, the European Association for Study of Liver Disease. So across these guidelines now, they support earlier screening for MASLD and risk stratification. They all look about the same. This is the AGA, the first algorithm for screening MASLD and MASH. And this really is designed for frontline clinicians, for internal medicine, primary care, endocrinology, obesity medicine, gastroenterology across the board, really people who are the frontline clinicians taking care of this patient population. And also it offers a very simple stepwise approach to risk stratification and management. So I'm going to use this example. They all look about the same, but as I walk through some of these points that I want to make. But before I do that, let me go and ask you a question. I just said screening is recommended. But when I say screening, what does that mean? What do I mean? What are we screening for? Are we screening for liver steatosis, hepatic steatosis? Are we screening for inflammation? Are we screening for hepatic fibrosis? Or are we screening for hepatocellular carcinoma, HCC? So anyone would wanna? Okay, think about it. I won't point out and ask questions. Think about it because I'll come back to that in a minute. So what is that we're screening for actually is liver fibrosis, because the health risks in this patient population, they increase with hepatic fibrosis stage. Now, this diagnosis of MASLD is important in and of itself. And as you can see with the first graph, which is going to be on your left-hand side, this is an older study. It's a population-based study, including over 280, actually close to 400 patients. And clearly it shows that a diagnosis of MASLD is associated with lower survival, higher mortality compared to general population expected survival. So in and of itself, it's important. But really what drives this mortality difference is the stage of liver fibrosis. So as you can see on this next graph, you can see how the risk, it diverges in different patients who are stratified based upon the liver fibrosis stage at diagnosis. So this is a larger cohort. Everyone had a liver biopsy, everyone had a stage of fibrosis at baseline, and when they were followed over time, there was a big divergence. And the risk increased with every stage of fibrosis as people were followed over time, with the risk being statistically significantly higher for patients with stage 2 fibrosis or higher. So that is where it is important. It's the stage 2 fibrosis that increases the risk for liver-related mortality and overall mortality. And that is the point that you'll keep hearing as I go through the presentation. And that is what is important for us to identify. So just as a very quick reminder, I will not spend a lot of time. Stage 2 fibrosis, again, we detected with a liver biopsy. And what it means is the presence of both perisinusoidal and portal fibrosis. It's a little less than stage 3, which is the bridging fibrosis, certainly less than cirrhosis, but it is clinically important fibrosis that we are detecting based upon a liver biopsy. So those studies that I showed, those studies were followed by multiple studies that now have confirmed that patients with F2 or higher fibrosis stage are at increased risk of all-cause and liver-related death, making it an important group for us to diagnose and to manage. F2 fibrosis or higher is what we're trying to diagnose and manage. So going back to this question, when we say we're screening for hepatic fibrosis. associated with MASLD. So that's, I think, is an important point to make. So now let's go back to this pathway. I'm going to walk through different steps with you to really help us figure out how do we handle our patient, Mr. A. So the very first step in this pathway is to really identify people who are at risk. So there are 3 groups that are called out. All of them are known to be at a higher risk for MASLD or MASH-related hepatic fibrosis. These are people with diabetes, type 2 diabetes, people with obesity who have at least one other metabolic risk factor, and patients that we see in our clinical practice, incidental finding of hepatic fibrosis or elevated liver enzymes. That's also another important group. And why is that? It's because when you look at them at a given point in time, let's just say if you look at 100 people with type 2 diabetes at a given point in time, 20%, 1 in 5 of them can have clinically significant fibrosis at that time. That's a pretty high burden of significant fibrosis at a given point in time. And that's the rationale for why these subgroups are listed as higher risk and higher patients that we need to be focusing on. And the rationale is that with the advent of new treatment that we will get into a minute, effective screening and timely diagnosis can potentially prevent progression to subsequent outcomes. So that's the rationale for why this is important for us to know. So patients with type 2 diabetes, patients with obesity who have another risk factor, these are without diabetes, or those incidental findings. So these 3 groups. Sounds good? All right. So then the pathway, after we've looked at these 3 groups, it recommends a 2-tiered approach to screening and risk stratification. The first tier, it relies on very simple, off-the-shelf, non-invasive tests. There are many that are out there, but most of these pathways, and I should say all of them, they recommend using FIB-4. So FIB-4, you can even Google it. There are multiple online calculators. You can access them easily. It's based on things that we have access to as part of routine clinical care. So it's the age, platelet count, and liver aminotransferases, ALT and AST. Simple, easy to calculate. You put in the value, it gives you a score. And we'll talk about how to look at those scores and what they mean. But it's simple to use, not perfect. We don't have time to go over the imperfections of these tests. It's not perfect, but it is similar and perhaps better than other available non-invasive, non-proprietary tests that we have access to. So that's the reason why this is chosen. And more importantly, there are many, many studies that have really demonstrated the predicted performance of FIB-4 for longer-term outcomes. So again, enough rationale for us to support the use of this test. So it will spit out a score for you when you put the values in, and there are different cutoffs that the guidelines recommend. I want you to remember one cutoff, and I shall ask you to remember a few cutoffs as I go down the path. The cutoff is 1.3. So 1.3 is the cutoff for FIB-4, and it is important because at that cutoff, the negative predictive value is very high. What do I mean by that? For patients that you see with diabetes or with those risk factors, where the FIB-4 is less than 1.3, the likelihood of having clinically significant fibrosis is very low. Depending on what study you look at, which population you look at, it's higher than 90. It approaches 95, 97% in most settings. So the likelihood that they have fibrosis that you're missing is very low. So meaning these patients can be managed in primary care, endocrine, primary settings. They don't need to be referred or need to be evaluated for further testing. We'll come back to that in a minute also. Patients who have another cutoff, if you have the mental capacity to remember, is going to be 2.67, but you can think about it and then put it on the side. This is where the risk is higher. And the initial version of the guidelines were recommending direct referral to specialty care for patients with a FIB-4 of 2.67. It is being revised, and I'll tell you why just now. It is because of this intermediate group. There was this group in the middle between 1.3 and 2.67, which really we used to call indeterminate because it was some mixed bag. We just couldn't tell. And that's why it was separated in the first iteration of this guidance. But since then, in the last few years, now we know this group is enough people with clinically significant fibrosis, and also their risk is higher than the risk in the low risk group. So really what's happening with the newer versions of these pathways is it's simplifying it. That's why remembering that 1.3 cutoff. So anyone who is less than 1.3 can be managed in primary care settings. The recommendations for these patients is to repeat the FIB-4 in 1 to 2 years to see if it changes. Anyone who is higher than 1.3 then moves on to the second tier testing, which most of these pathways are recommending performing liver stiffness measurement. So liver stiffness measurement, this is guidelines mentioned FibroScan. How many of you here have heard the term FibroScan? It's a test, I think, again, commonly available in most practice setting. It's a special ultrasound technology that measures liver stiffness in a unit called kilopascals or kPa. So I'll talk about that also in the next few slides. But that's the second tier applicable to patients where the FIB-4 is more than 1.3. So less than 1.3 can be safely managed, just follow them up. Those more than 1.3, send them for a second tier testing, let's just say the liver stiffness measurement with FibroScan. This one study, I think, really informed much of the guidance as we were putting it together for the AGA, and then many other studies have really provided confirmatory data to support the cutoff for FibroScan. In this study of over 400 patients who had both the FibroScan and liver biopsy with suspected MASLD, the cutoff for the kilopascal was 8. So remember, I asked you to remember a few cutoffs. 1.3 was 1, and this is the second one that I want you to remember, 8. So 8 has similar characteristics. Below 8, the negative predictive value is quite high for clinically significant fibrosis. Above 8 is when you start thinking about the next step. So just moving on to the same second tier path in the pathway, for patients who have a FIB-4 of more than 1.3, and then you have them get the FibroScan, look at the cutoff, less than 8, the negative predictive value is high, both in primary care and in endocrine settings, and these patients can stay in primary care setting, would not need a referral. The recommendation for them is the same. Repeat the test in 1 to 2 years. This is based upon just small amount of information, little data, but that's the guidance. Most of the guidance statements are converging on that. I think it might change over time, but for now, just repeat it in 1 to 2 years. For those who have a cutoff higher than 8 is where you would refer them for specialty management to gastroenterology, to hepatology, for MASH diagnosis and for management. So sounds good? All right, so I'm going to now take you back to our case. So Mr. A's investigation, after they were done, his FIB-4 was 2.7, it's higher than 1.3. And for that reason, he underwent the FibroScan, vibration-controlled transient elastography testing, and his liver stiffness measurement is 9, more than 8. So it is, again, indicating that he's not low risk for sure. He is above the cutoff, and that's where you would recommend sending the patient to specialty for further evaluation and for testing. So in the audience right now, how many of you are GI fellows or GI faculty? Wonderful. So let's just say the patient comes to see us in our clinic, and his cutoff is, his value is 9. How confident are we in making a positive diagnosis of his stage of fibrosis based upon that value? So I want to just take a minute. Yeah, I just want to take a minute here. So the negative predictive value is pretty high. So which is why I think it's okay. You have to be comfortable in primary care settings to keep the patients in the primary care setting. But the positive predictive value is not as high as 90%. And really, it varies depending on what study you look at, which population you look at, and what cutoff you use for some of these tests. So as you can imagine, the specificity or the positive predictive value, which you need to be high to make a positive diagnosis, it varies depending on the cutoff. And this is a very nice systematic review that makes that point. So here I've listed the different cutoffs for making a diagnosis of F2 or higher. And I have depicted the positive predictive value or specificity at this cutoff. So if you just look at the very far left, at 8 kilopascal, the cutoff that we were just talking about, the positive predictive value is 64%. What that means is that 40% of them actually will not have F2 fibrosis, you're over-diagnosing, over-calling the stage of fibrosis, then it is important to make the accurate diagnosis for fibrosis because this actually informs our treatment recommendations. We'll go over that in a minute. And also it has implications for ongoing monitoring and surveillance. So you want to be comfortable in specialty settings to make a positive diagnosis. So the point is that these cutoffs, I think they are not really very firm and very informative for specialty settings. We have to think a little bit more about where they fall. So if you just look at the follow the spectrum, the positive predictive value or the specificity, it is between 60 and 80% with the cutoffs between 8 and 9.8. So that's sort of the area where I think it's not where we need to be. But the specificity, it does approach in studies that use the cutoff of 10 or higher for F2 fibrosis. So I think based on that, I at least think, and I think we'll see that in the newer iterations of these guidelines, is that it's okay and probably reasonable to consider a second test to confirm the stage in patients where the kilopascal or the liver stiffness is in between 8 and 10. And over 10, I think we can be a little bit more confident, but that 8 to 10 is where it might be reasonable to consider another test, such as an MR elastography, which is an MRI-based technology. It also looks at liver stiffness. I think most people have access to it, but that might be a good sweet spot for the second testing to confirm the stage of diagnosis. And that's also with new information that we are coming up with the MRE, it is useful test. It is more expensive, less available, so cannot be recommended for first-line testing. But as a second-line testing, I think it's a very reasonable test. This is a large meta-analysis that included over 798 patients, close to 800 patients, that really shows that it has excellent performance for detecting both staged clinically significant fibrosis and cirrhosis. And the cutoffs here, I'm focusing a lot on the cutoffs, for F2 is 3.14. And I try to have some clues for me to memorize. Remember I told you 1.3 for FIB4? This is just the reverse, 3.1. So just remember 1.3, 3.1, it will help anchor some of these things that we have to memorize. So 3.14 is where F2, you can detect that and diagnose that. And the cutoff for cirrhosis is 4.45. So if you can remember it, that's great. If you can, that's fine. But those are important information. I think very new data to really inform how can we screen and how can we risk stratify and diagnose patients with MASLD and clinically significant fibrosis. So Mr. A had the liver stiffness measurement, remember, of 9 in that gray zone. He underwent an MRE, and on MRE, his number, his kilopascal is 3.5. It's more than 3.14. So he falls between the F2 or F3 range. So now, question to you is that what should be the next step for Mr. A? So one option is that we don't need to do anything. No immediate action is needed. The non-invasive testing that we had, they're suggestive of MASH. They're not suggestive of MASH with clinically significant fibrosis. Second option is they are suggestive of MASLD with low risk of progression, and we can just give him lifestyle advice only. Or they are suggestive of MASH with clinically significant fibrosis, and he should be considered for MASLD MASH treatment. See, okay, thank you. All right, absolutely. So his findings are suggestive of MASH with clinically significant fibrosis, and he should be considered for MASH and MASLD treatment. So now that we've made that determination, he has a diagnosis of MASH, and remember he had type 2 diabetes. What do you think? I know he also had obesity. So what changes to his care would you recommend? You can consider treatment with type 2 diabetes medication with evidence of benefit in MASH, along with lifestyle intervention to improve overall health. Or you can just discuss lifestyle changes that will address obesity, but you don't have to worry about anything else. Or this option 3 is that it's not really necessary to make any changes. Perfect, perfect, perfect. So you are right on. Absolutely right. And you go ahead and make that change to Mr. A's care. You discuss it with Mr. A, and then you make a joint decision that he should make some dietary changes. he should increase his physical activity, and you also agreed, remember he was only on metformin? You also agreed that he should change his medication to an agent that has shown benefit in people with MASH. So multi-pronged approach to his treatment, which is consistent with the treatment recommendations for patients with MASLD who are at high risk for liver fibrosis. So this table is also from the AGA guidance. And if you could look at the high risk column, you'll see a few things that are important to remember. One is that the management of these patients who are at high risk for fibrosis needs to be multidisciplinary. It's not just a liver disease. So it has to be really managed with primary care, endocrine, diabetes, obesity specialist, and liver specialist. So that is an important concept. Second is it has to be multi-pronged. There have to be recommendations and focus on lifestyle intervention. Weight loss is going to be important. We'll talk about that in a minute. There are new pharmacotherapies for MASH. And we'll come to that also in the next few minutes. But it is important to emphasize that the management has to focus on cardiovascular disease risk reduction and good diabetes care. And the diabetes care also becomes relevant because there are medications that are approved for use for patients with diabetes that also have now efficacy, or at least evidence for efficacy early in patients with MASH and MASLD. So it makes it really important to talk about some of these treatments that I will do it in a minute. But before that, let me just quickly highlight the importance of weight loss in managing these patients. So this would not come as a surprise to any of you. All right, good to talk to you too. So you're looking for great weight loss, and really it's the greater weight loss that is associated with more benefits in patients with MASH. So this is a figure now, it's a little bit older data, but again, it's been really proven and confirmed in many studies, is the degree of weight loss matters. So these are multiple different bars, and the stratified by the amount of weight loss. So if you start from the lower to the higher, the first one, which is showing as a purple on my screen, is a weight loss of less than 5%. The next one is between 5 to 7. The yellow is 7 to 10%. And the last one, sort of the brown one, darker one, is greater than 10% weight loss. You start seeing improvement in hepatic steatosis with weight loss as much as 5 to 7%. So that is important. You have to have that much weight loss to really see regression or improvement in hepatic steatosis. But really for improvement in fibrosis, which is that we care about, you need at least 10% weight loss for fibrosis regression. So that is important, 10% weight loss where you start seeing differences and improvement in fibrosis. So hold on to that because there's another point that I'm going to make in a few minutes that will come back to this 10%. And there are many treatments that can help with that weight loss, obesity medications, bariatric surgery. Of all of these options, they offer better, more weight loss than lifestyle interventions. So with lifestyle changes only, diet and exercise, which we recommended for Mr. A, at most you see about 2 to 5% change in weight, which is not to the degree that we want to make a difference in these patients. With some of the newer treatments, such as semaglutide, it approaches 15%. With tirzepatide, which is the combination GLP-GIP, you get to be about 20% weight loss. So it is approaching the weight loss that you can actually expect to see with bariatric surgery. And all of these treatments now have data for patients with MASLD. And I'm going to talk about that, starting with the bariatric and metabolic surgery. So up until recently, there were really no convincing data on comparative effectiveness of metabolic bariatric surgery compared to lifestyle intervention and best medical care. This trial came out a few years ago now, the BRAVES trial, that really provides that level of data that we were looking for in about over 280 patients with MASH who were randomly assigned to 3 groups. One was lifestyle modification, The other two were surgery groups. One was Roux-en-Y, and one was sleeve gastrectomy. The likelihood percentage of patients who met the primary endpoint was much higher in the surgery groups compared to the lifestyle intervention group only. And the same thing with fibrosis improvement. So about 37 to 40% of patients had at least improvement in one stage of fibrosis, compared to 23% in the lifestyle intervention arm only. So there is clearly the surgery groups did better compared to the lifestyle intervention group only. 23% to 39% difference. There are a few other points that I want to make about this study. In addition to looking at the difference between the lifestyle intervention and surgery, there are two surgery arms, the Roux-en-Y and sleeve gastrectomy. Roux-en-Y patients had more weight loss than sleeve gastrectomy patients, but the success rate for MASH was very similar. So I think that was important. We'll have to get more data to really confirm that that was an important finding. There was one other important finding that I'm not showing in this figure here, was that the likelihood of meeting the primary endpoint increased with greater weight loss, but up until a threshold, which was 20% weight loss. So from 10% to 20%, as people lost more weight, there were more and more people achieved the primary endpoint, but then leveled off at 20%. Patients didn't achieve, or not more likely to achieve the primary endpoint if they lost more weight beyond 20%. So to me, it looks like sort of the sweet spot to be in is between 10% and 20% weight loss. We'll see if other data confirm this, but that is, I think, notable takeaway for me from this paper. So 10 to 20% weight loss. Moving from surgery on to more medical treatments that we have access to and we offer to our patients. These are very new data about semaglutide in patients with MASH, with F2 and F3 fibrosis. Again, this is the group that we want to target, the high-risk group. And in this study is a phase 3 trial of 800 patients with MASLD who were given semaglutide at 2.4 milligrams once a week and compared to placebo. And based upon these earlier data, there is a significant difference in the primary endpoint, which was resolution of MASH inflammation without worsening of fibrosis, so about a twofold difference. But also, I think more notably, carrying the theme, the high rate of fibrosis improvement in patients who received the semaglutide compared to placebo. And the numbers here, interestingly, is 37% for semaglutide and 22.5% for placebo, which are not very different than the numbers here in this graph with surgery. So again, we cannot make comparisons across studies, but really it was interesting to see that the numbers are about the same, 22 to 37, 15% difference in fibrosis improvement with use of semaglutide versus placebo. Also, we have data on tirzepatide. This is from phase 2 trial, so we'll have to wait for the phase 3 study, but again, very encouraging data. In tirzepatide, also, there was a higher rate of fibrosis improvement by at least one stage in patients who received tirzepatide versus placebo. The difference seems to be about 20%, but again, we'll have to see if that really holds true in larger studies, phase 3 studies. So multiple studies, bariatric weight surgery, semaglutide, tirzepatide, impressive amount of weight loss, and improvement in fibrosis by at least one stage in a reasonable number of patients. And these are all options for patients with diabetes. So based upon what I just shared with you, with changing the type 2 medications, which medication would you recommend for Mr. A? Peglorazone, metformin, he's already on metformin, sitagliptin, or semaglutide? Very good, very good. So he started, you told him, he said, yes, let's go for it. He started semaglutide, but he's a curious patient. Now he's asking you a question that I have clinically significant fibrosis, probably F3, and I'm starting this new treatment. Can you tell me a little bit about my future risk for progression to advanced liver disease, cirrhosis, or especially hepatocellular carcinoma, which he may be at risk for? So we don't, of course, have long-term large clinical trials to answer this question about whether these drugs will prevent future risk of cirrhosis or liver cancer. But we looked at it just recently using retrospective data from a National Veterans Administration cohort of patients. So these are patients who had diabetes, seen in the national VA healthcare system, and who had started GLP-1 receptor agonist. Most of them were taking semaglutide. And we matched them with patients who looked like patients who were using semaglutide, but who didn't, among this large group of people. So there were close to 20,000 people in this study that had MASLD, type 2 diabetes, and were using GLP-1. And we matched them with 140 non-users in what we call an emulated clinical trial design. We'll go over the methods if you want to, but just to make the point, these patients were followed from the start of the treatment with over time to the primary endpoints of HCC or cirrhosis during the follow-up. And use of GLP-1 was associated with a lower risk of progression to cirrhosis in these patients who didn't have cirrhosis to begin with, and also lower risk of HCC, although for HCC, the absolute risk reduction was small because it's a rare outcome. So there's a signal towards that, but not a large one. And it was not statistically significant in patients who'd already progressed to cirrhosis. To us, what it indicates is promising data. For these drugs to really work to reduce liver-related outcomes, they have to be used earlier on before patients have approached to the stage of cirrhosis. But also, despite being encouraging, we really have to wait for larger clinical trials to really prove and test this hypothesis. But overall, encouraging data. So based on these data, you share these data with Mr. A, he's reassured. But his partner now asks the question if there are any additional liver-directed treatments that may be of use or help Mr. A more. And the answer is yes. This is resmetirom is the first FDA-approved pharmacotherapy for MASH. Have you heard about resmetirom? I'm seeing some heads nodding. Yes. So this is the first treatment that is approved for MASH. It was approved just recently, less than a year ago in 2024. It can be used in conjunction with diet and exercise, and it is indicated for patients, the same patient that we've been talking about, with MASH, with stage 2 and 3 fibrosis. It can be taken orally once a day. The dose is different based upon the weight. So for patients who are less than 100 kilograms, it is 80 milligrams. For those who are more than 100 kilograms, it's 100 milligrams. Once a day, seems to be safe, seems to be easy to take, and there are not really very many contraindications. There are few areas that are important to talk about. It's not recommended for patients with cirrhosis, compensated or decompensated cirrhosis. So one has to exclude or make sure that we're confident about the diagnosis of cirrhosis before we give that to the patients. Also, patients who are drinking alcohol, it's not recommended for patients who are also drinking alcohol, so that MASLD group that we talked about earlier. And this recommendation is based upon a large study of over 966 patients with MASH who had F2 or F3 fibrosis, the MAESTRO-NASH trial, that really demonstrated that this drug is safe and effective in improving fibrosis again. 25 to 14%, about a 14, 15%, 11%, 11 to 12% difference in fibrosis improvement in this trial, and that the recommendation for resmetirom is based upon these data. This guidance is from AASLD. It is about use of resmetirom in patients with MASH and MASLD. And I wanted to make a point about this guidance. You can, of course, use it to really decide who to start the treatment on and how to monitor. But I think this guidance is important for another major reason. This is the first time that any society or guidance has endorsed or recommended patient selection for treatment based upon non-invasive testing in MASLD. And I think it's important because the diagnosis of steatohepatitis or MASH really is a histological diagnosis. What it means is that you have to do a liver biopsy in everyone. But really, how many times do we do a liver biopsy? It has price, but it is invasive. Patients don't like it. And really, we as clinicians don't like it anymore. You really want to use non-invasive tests to inform patient selection and also to help inform monitoring over long. And there really were no consensus or recommendations, strong recommendations to use non-invasive tests for these critically important decisions. So that's why I think this guidance is important, because this is the first time it is recommending using non-invasive tests to really inform patient selection for treatment and also how to monitor them over time using these non-invasive tests. So based upon this guidance, in the absence of liver biopsy, patients can be selected for resmetirom if their FibroScan or the VCTE, the liver stiffness measurement, falls between 8, remember that 8 cutoff that I want you to hold on to, and 15. 15 is where you start suspecting cirrhosis based upon VCTE. And these patients cannot be on resmetirom if they have cirrhosis. So 8 to 15 on VCTE or FibroScan is the range where patients can start on the treatment based upon non-invasive tests alone. The corresponding cutoffs for MRE, remember the flip of 1.3 was 3.1? 3.1 to 4.4, which is the cutoff for cirrhosis. So it's really providing this very practical guidance. It could change over time as more data emerge, but for now, really provides a practical guidance to use these tests for decision-making. So I think that's really important to make a note of. Now, yes, you might see patients who are falling outside of these cutoffs, and that's where you can use, individualized decision-making with the patients if they're outside of this range. But within this range, one can move ahead and make recommendations for treatment. So that's very important, and it's a good conversation to have. But how does it help the case for Mr. A? Remember, his wife was asking whether he could be on another treatment alongside with the GLP-1 that we started him on, sort of the concurrent and concomitant treatment. For that, it doesn't really help the guidance very much, because really, as we stand right now, there are insufficient data to guide concurrent treatment. Which one to choose first? How do you really go about it? We really will have to wait for more data. Based on where we stand right now, in at least this trial that used resmetirom, it excluded patients who started GLP-1 receptor agonists within 6 months of randomization. So that's one piece. So the way I think we can operationalize it is that patients who are already taking a GLP-1 receptor agonist, maybe we wait for a few months before we start resmetirom. But I think really the decision has to be made upon the patient profile. What's happening, if there's any response to the ongoing therapy, what is the stage of fibrosis, what's the concern for progressive liver disease. So it really has to be individualized based upon how do you go about initiating resmetirom in patients who are already taking GLP-1. And for patients, again, who are not taking GLP-1 or neither resmetirom, do you start both of them at the same time? Do you start one, wait for the other one? Again, really no clear guidance. It is based upon your practice, decision-making along with the patient, and looking at the risk of progressive liver disease. So yes, it's an important question, unanswered question. Right now, we'll have to really deal it case by case. More information will probably emerge in the next few years, but right now, for now, that part we couldn't really address with Mr. A. So now Mr. A is on treatment, and now you want to follow him over time to see if it's getting better or he's worsening. How can we help with that assessment? And that's where also the guidance, the AASLD guidance that I just mentioned, it helps, although it makes a point that these data are based upon limited information for now or indirect information for now, and it might change, but I think still useful. It's still practical. So for the FibroScan or VCTE, for the liver stiffness measurement, you want to look at a change, but it has to be 25 to 30% change from the baseline. Because anything less than that could just be interperson variability. So if you're starting at 9, it has to be 25 to 30% lower or higher than 9 for us to call it clinically significant change over time. For MRE, it's about 20% change in liver stiffness measurement over time for us to be really thinking of that seriously, because these are the changes which are associated with predicting clinical outcomes in observational studies. They have not been tested in clinical trials. We're waiting, but at least we can use this information to inform ongoing monitoring using non-invasive testing for our patients. So I am going to wrap up with some of these summary points that I want you to walk away with. One is that guidelines now do recommend earlier MASLD screening and risk stratification. Remember, we talked about 3 risk groups: diabetes, obesity with another risk factor, those with incidental findings. Those patients in your clinics should be screened and risk stratified for MASLD-related fibrosis. You can use non-invasive testing for this purpose. FIB-4 is recommended at the first year. Remember, the cutoff of less than 1.3 can stay in primary care. More than 1.3 should be referred for the second-line testing, second-year testing, which you can use FibroScan, VCTE, and based upon that, anyone with a cutoff less than 8 can stay in primary care. More than 8 should be recommended for specialty evaluation and referral. We do have newer treatments as of today. Resmetirom is the only FDA-approved treatment for patients with MASLD and F2 and F3 fibrosis. There might be others that might be joining this group very shortly. But there are several medications that are used to treat diabetes that we're very familiar with, semaglutide, tirzepatide, that also have demonstrated efficacy in MASH, and we'll wait for more data, and I think they'll be getting FDA approval hopefully in the next few years to come. But before I wrap up, just wanted to leave you with this. I showed you this to you before. The point here that I want to make is that MASLD is not just the liver disease, as you all know, and it really does require multidisciplinary management approach. So MASLD management is multidisciplinary management, has to be managed as a team. And the focus, of course, there are new treatments for liver-directed treatments for this condition. But again, I want to emphasize that we really need to have an ongoing focus on lifestyle intervention, weight loss, cardiovascular disease risk reduction, and great diabetes care. And with that, I will end, and I'm happy to take any questions.
Thank you, Dr. Kanwal, for that beautiful presentation, clear, didactic, logical, great. I just begin with a question first, and you sort of hinted to this. I mean, for centuries almost, medicine has been at the mercy of pathologists and radiologists to make diagnoses, and you call it a disease. It's probably diseases, right? And you indicated earlier on that there are multiple etiologies. Do you think that as we learn more about what are the etiologies of this, that we might be able to have better directed therapy to the cause? Because a lot of fat people, a lot of diabetics, a lot of individuals who need may have different mechanisms of causing the fibrosis. So where are we in terms of understanding the molecular basis so that we can have real targeted therapy?
It's a great question. A lot of that discussion came, lots of focus on that conversation happened during the nomenclature change, because in a way it was oversimplifying the condition, not really paying attention to the fact that there could be multiple pathways working in the same patient also. And you're absolutely right. There's lots of work that's happening at the molecular level, lots of omics work, lots of genetic work, and also integration of all of these factors that can happen in a given patient. So the way we think about MASLD and even the names might change as we get more information. So where we are right now, at least with this nomenclature, there is a specific section in that paper that talks about some of that, and the fact that this offers the flexibility and really, acknowledging the fact that this will and has to change over time. And yes, the directions of the treatments is going to be probably different depending on the underlying mechanism and underlying pathways. Right now, we have this group that we call cryptogenic. We don't really know what that is. Even the ones that we call something might have different pathways. So lots of work is happening, but will need to continue to happen for us to get there. But at least there's an acknowledgement.
Yeah, but truthfully, the way you presented it today, as practicing clinicians, we need to have something by which to handle these patients.
Absolutely.
Dr. Goldberg.
So one of my concerns with prescribing resmetirom is that it's based on conditional approval based on 1-year data. We saw with obeticholic acid and PBC, you have this population, we get conditional approval, then when it goes to full approval, it gets, not approved, whatever term you want to use.
So if you're starting a patient on the medication, do you actually tell them this is a drug that's conditional approval 1 year and it's possible that in a few years we may find out that it's dangerous, arguably in the case of obeticholic acid, or at the very least, doesn't provide a benefit.
Yeah.
How do you counsel them when, especially if they're overweight and semaglutide is an option there?
Yeah, yeah. It's a great point. I think a lot of that came about with the ASLD guidance on resmetirom also. It's encouraging to have a drug finally. It also opens a pathway for other drugs to get approved also. So I think that experience is useful. But can we be too excited about it? Probably not. So there is that, concern that you mentioned because it's just 1 year data. And even with 1 year data, the improvement was there, but it's modest. Most people didn't improve in the first year, and we have no idea what will happen in the next year. Yes, it could continue to improve. It might just flatten out. And of course, the long-term outcomes we don't really know about. There's a special consideration and concern from endocrinologists because it works at the thyroid hormone receptor level, and they are concerned that there might be unintended consequences or long-term stuff that might happen. We just don't really know. So yes, I think this is important concerns. For me, practically, I tell patients, we just don't know what will happen at the end of the first year. I do not really know what's going to happen after that. It seems to be very safe. And really, it is a patient-driven decision then. And also, I think in our clinical practices, most of the people are on something else. And I think there's so much data that have been accrued for diabetes and obesity with some of these drugs that are safe and also have other beneficial effect on cardiovascular risk reduction, that there's no reason to ignore that data. So really, I think it's a conversation, and I think that's why probably most people are on other agents and on resmetirom.
Dr. Jones.
Hi, so hopefully this is a quick question. Can you talk a little bit about your approach to the second line testing in settings where elastography or FibroScan might not be available? For example, we have a number of patients that we cannot get this test for. So if they don't have private insurance, for example, we cannot get a FibroScan or even ultrasound with the elastography. So how would you modify the algorithm that you
Right.
showed in terms of stratifying?
Yeah, that's again a great question. So I'll address it from multiple different ways. One is I think doing some screening is better than not doing anything. So that's why, despite some of the pushback that we got for FIP4, we recommended FIP4 because there was this competing issue about some other tests that are proprietary that are now FDA approved, but they're expensive. So that was the reason you want to have a test that we routinely have those values available, and at least it gives you some guidance to use. You might not really use it for other things, but at least gives you some guidance. So that's one. Depending on patients who have access to insurance and to resources, but don't have the FibroScan or MRE, again, there are resource limitations. There are some blood tests, proprietary blood tests that are available. One such blood test is ELF, that I think most people are getting, they'd like to have that option, especially in primary care, because not every primary care clinic or hospital has access to FibroScan or MRE. So that test, I do not feel very strongly about it personally. We have started to see that in guidelines and in clinical care pathways. The reason I don't feel very strongly is that it's unclear what the cutoffs are. There's still mixed data. We don't really know what those cutoffs are. And second, it's expensive. It's as expensive as FibroScan. So it is, I think that's one of the reasons that we still go ahead with FibroScan, but this is a reasonable option, ELF, if available and patients can afford it, absolutely can be considered. And there are many other tests also that we can talk about separately.
So I want to thank again Dr. Gene Schiff for being here and for his family to support this lecture series. Gene, my blessing to you is you should be here next year and listen to the lecture again. And we hope everyone enjoyed it as much as certainly as I did.